Hi friends, today we will see the drugs which are acting in diabetes. We know that diabetes is a very common disease nowadays. Earlier it was used to be a disease of elite class, but nowadays it doesn't choose the patient from elite class only. It is found in every strata of the society. And its consequences are very dangerous, and therefore it must be early diagnosed as well as it must be strongly treated so that the person can have a normal life. So therefore these drugs are very important, and we have to have a detailed knowledge of these drugs along with their adverse effects, etc. So let us start with uh, diabetes mellitus and its pharmacology. Now, diabetes mellitus, as we know, is a group of common metabolic disorders that share the phenotype of hyperglycemia. Hyperglycemia is the main sign of diabetes, and it is caused by insulin deficiency. And it is also having insulin resistance, means however may be the insulin contained in the blood, it will not reduce the blood sugar level. So that is insulin resistance. It is also a component of diabetes mellitus. So it is a state of high blood glucose concentration, that is hyperglycemia, with fasting plasma glucose of 126 milligrams per deciliter and post meal plasma glucose level of more than 200 milligrams per deciliter. Also, HbA1c is a very important parameter in this diabetes. If it is more than 6.5 grams, then it is definitely a diabetic patient. And this diabetes is characterized by glycosuria, polyuria, polydipsia, wasting of the muscles, and sometimes ketoacidosis. Now there are four clinical classes of diabetes. Type 1 is the IDM. It is beta cell destruction due to autoimmune cause. That is, the antibodies may be detectable in the blood. So that is type 1 diabetes. It is usually leading to absolute insulin deficiency, and it is also prone for ketoacidosis. There is absolute insulin deficiency. There is total loss of beta cells in the islet of Langerhans, and therefore there is no insulin available. Then second type is the NIDDM, non-insulin dependent diabetes. The type 1 is insulin dependent, this is non-insulin dependent. So results from progressive insulin secretory defect on back of insulin resistance. Progressive insulin secretory defect on the back of insulin resistance. So these two things are together. The beta cell number may be normal or may be decreased. Insulin secretion may be more or normal or decreased. And there is a high genetic disposition. If the parents are diabetic, then there are chances that the progeny would also be diabetic. And second thing is that this is a late onset diabetes. Its onset is usually after 40 years. Now in this diabetes, there are abnormal glucose receptor on the beta cells. The receptors on the beta cells which sense the glucose, they are abnormal. So they require higher concentration of glucose to get stimulated. Plus, there may be deficiency of the beta cells. So these two factors together may decrease the insulin secretion. Secondly, there is decreased sensitivity of the peripheral tissues to insulin due to downregulation of insulin receptor. Their insulin receptors on the peripheral tissue, they are downregulated, means their sensitivity is less and their number may be less. So this leads to insulin resistance. Thirdly, there can be excess of glucagon-like hormones or obesity which cause relative insulin deficiency. It means that glucagon-like drugs, they increase the blood sugar level. So insulin will be required in more amount to decrease that level of blood sugar. And secondly, if there is obesity, then insulin has to work more, and therefore a more insulin requirement is there. So if there is already little deficient insulin secretion, then this obesity will add to that catastrophe, and therefore there will be more insulin deficiency. Therefore obesity is very dangerous if there is diabetes. Now then, other diabetes is gestational diabetes. This occurs during pregnancy. There is glucose intolerance in pregnancy. Other diabetes types, they may be because of genetic defects of the beta cell function. There may be genetic defects in the insulin action. There may be diseased exocrine pancreas, because the endocrine betas, islet of Langerhans and beta cells, alpha cells, they are the endocrine part of the pancreas, whereas there is the outside is the exocrine pancreas, which secretes the enzymes like lipase, etc., in the taking part in the digestion. So that part, suppose the exocrine pancreas is fibrosed, then these endocrine functions will also be lost. So these are the various type of diabetes. Now the complications caused by diabetes. The long-term consequences of metabolic derangement, because diabetes causes total carbohydrate, protein, fat metabolism deranged, and therefore this may lead to two types of complications or consequences. One is the macrovascular complications and other is microvascular complications. The macrovascular ones, they are associated with accelerated atheroma and its thrombotic complications. Atheroma, the vessels, there is deposition of the calcium, etc., deposition of the cholesterol leading to atheroma formation, and then calcium deposits in that. So it will gradually obliterate the vessel. So this complication will occur in large and medium sized vessels, and these will lead to coronary heart disease or peripheral vascular disease. If they occur in the cerebrovascular vessels, then it will cause stroke. So that is macrovascular, it is seen with the eyes. Whereas there can be some microvascular changes which leads to neuropathy or nephropathy or retinopathy. So these are the microvascular pathologies in very small vessels. So these two types of complications can be there because of the long-standing diabetes. So in this figure we can see the microangiopathy. Cerebral vascular infarcts or hemorrhages can occur because of the microaneurysms which are caused in the cerebrovascular vessels, cerebrovascular tree. Then there can be retinopathy in the eye, there can be hypertension because of diabetes, then there can be atherosclerosis, myocardial infarction, then peripheral vascular diseases which can cause gangrene in the foot, that is diabetic foot, peripheral neuropathy, autonomic neuropathy which can cause urinary bladder, loss of urinary bladder control, etc. So all these are long-term complications of untreated diabetes. So in the fasting state and in the prandial state, the glucose homeostasis is a very crucial one, and when there is a sufficient amount of insulin present, it can be well regulated. In the state of deficiency of insulin, this glucose homeostasis then goes heavy, and therefore there is derangement in all these metabolic processes, which leads to then complications. So we know that insulin is the most important hormone which is secreted by our beta cells of islets of Langerhans, which is deficient in diabetes. So Let us know something about insulin. It was discovered by Banting and Best in 1921, who received the Nobel Prizes for that. Then it was isolated in crystalline form in 1926. Sanger, the scientist who developed the chemical structure, who explained that chemical structure of insulin in 1956. Now the structure of this insulin is two-chain structure. It is a polypeptide. A chain has got 21 amino acids and the B chain has got 30 amino acids. So total 51 amino acids. The molecular weight is 6,000. And it is synthesized in the beta cells of Langerhans of pancreas. It is a mixed type of synthesis. It is synthesized as pre-proinsulin, which has 110 amino acids, single chain polypeptide. Then there is proinsulin, 86 amino acids, and then by removal of a C peptide from this 86 amino acid proinsulin, we get insulin, which has got 51 amino acids. And after its synthesis, it is stored in the granules of the beta cells. So this is the structure of insulin. Pre-proinsulin, then there is a cleavage, and then folding is there. Proinsulin is folded, and then C peptide is removed, and we get insulin of 51 amino acids. So this is a picture of beta cell. We can see the receptor there, or the channel, which can be called as potassium channel, ATP sensitive potassium channel, through which potassium enters. And this entry of potassium is blocked. It is blocked by ATP. This ATP comes from the phosphorylation of glucose 6 phosphate, that is caused by the stimulation of GLUT1 receptor. This GLUT1, it transports glucose from the periphery into the cell, and then glucokinase acts on that. It causes glucose 6 phosphate, which is metabolized into ATP. This ATP level blocks the entry of potassium. So decreased potassium will then cause depolarization of the calcium channel, and this calcium channel will open up. Calcium will enter. It will cause the release of the stored insulin in the granules. It causes exocytosis, and then there is release of insulin. So secretion of insulin is caused by glucose. The glucose is the most important factor to cause secretion of insulin. So glucose by GLUT1, it enters, it converted into glucose 6 phosphate, increase ATP, blockade of potassium channel leading to depolarization of calcium channel, increased calcium level in the cell, and then exocytosis of the insulin. So that is the sequence of secretion of insulin. I think we will stop here. We will continue with this lecture next time. Thank you.